All right. Hello, everyone, and welcome to this week's COVID-19 office hours. I am just going to spend a couple of moments going through some housekeeping and logistics slides, and then we'll get right to our great panelists and presenters for today. So, recording of the webinar along with the slides and a copy of the content from the chat will all go to the HUD Exchange. Just do give us a couple of business days and we'll be sure that they are posted at the link that is up there on the screen. We do now have, as you all are experiencing, an event password. That password does not change from week to week. It should auto-populate for you all, but I understand it is not for many folks, and we apologize for that. But the password is easy to remember and you can just write it down. It's HUD123 each and every week. If you have any audio issues, we encourage you to switch over from computer audio to your phone because the phone tends to be more stable in terms of a connection. And you can switch over to the phone number at any time by entering the information that's up there on your screen right now. We are going to communicate with everyone today through the chat, which is hopefully common to all of us by now after doing many weeks of these, but just a quick reminder for us all to find the chat, please look over on your WebEx screen all the way over to the right, and you should see what looks like the chat bubble and the word chat. When you are using the chat functionality to send us all of your questions, messages, feedback that you've got, please take just a moment to make sure that the to line is selected to everyone. That makes sure that all of the attendees, as well as all of the panelists and presenters, get those messages as they come in. And I want to also, just as a very brief reminder, let folks know that you should look at your chat later on to see a link to a poll question. We are going to do poll questions again this week, and we'll give you a little more context and information on those poll questions when we get to them. And with that, I'm going to turn things over to Norm Suchar from HUD's Office of Special Needs Assistance Programs. Norm?
Thank you so much, Natalie, and welcome everyone to Office Hours this week. Thank you so much for joining us. I want to first recognize that we got some positive feedback about the music. I'm not sure actually how we select music, but we will do our best. Also, want to introduce our presenters very quickly. Again, I'm Norm Suchar from the Office of Special Needs Assistance Programs at HUD. You'll also be hearing from Marlisa Grogan and Sharon Singer from the SNAPS office. We also have Mandy Wampler, who is with one of our CPD's field offices, one of HUD's field offices, is going to give a presentation today, so we're very excited to hear from her. We have a couple great presentations we're very excited to tell you about. One is from the Alameda County Healthcare for the Homeless. Lucy Kasdan and Seth Gomez will be presenting for us today. And also we have a presenter from the Connecticut Department of Mental Health and Addiction Services. Alice Minervino will be doing a presentation for us. We will have our regular Centers for Disease Control and Prevention update. That'll actually come later in the program than we normally do it. We've switched things up a little. So you'll be hearing from Sapna Morris and Ashley Meehan from CDC. And we have a whole host of people from SNAPS, from HUD, from VA, from our technical assistance providers and everywhere to answer questions in the chat window. So as Natalie mentioned, if you have any questions, please feel free to type them in the chat window. We'd love to try to answer as many of those as we can. So with that, I'm very pleased to introduce Seth Gomez and Lucy Kasdan from Alameda County. Lucy, I'm going to turn things over to you.
Great. Hi, good afternoon, everybody. We're really excited to be able to join you all. My name is Lucy Kasdan. I'm the director of Alameda County Healthcare for the Homeless, and I'm joined by my colleague, Seth Gomez, who is our senior pharmacist here to present to you all today. Next slide, please. Actually, you can go two. You can go one more forward. Thank you. All right. So really wanted to start with our presentation here today in terms of kind of describing our approach to the COVID-19 response. And the first couple slides here really highlight the work that we did really from the beginning and certainly continues obviously this week, most recently with the updates on the Johnson & Johnson vaccine, really starting with education, outreach, information, and resources. And we really took the approach here in our county about really thinking about kind of who touches our homeless population, thinking about not just, of course, our formal contracted providers and kind of that network, but really extending it out to all of the churches and advocacy groups and volunteers who are really out engaging, I think most prominently with our unsheltered homeless population. And so we really kind of cast a wide net. We started this very early on, convening weekly calls, one for shelter providers and using that term quite broadly, and then one for kind of outreach providers. And again, really wanting to engage a large community. We from week to week have somewhere upwards between 60 and 80 people join each one of those calls. And those calls have really become kind of a central key place for us here in our community to really for us to provide information, respond to the needs, respond to what folks are seeing out there, and for there to be kind of this integration and collaboration across. We also, from the very beginning, and continue to be really a hub of supplying PPE and other supplies out to providers. And again, not just providers who have that budget line, but really, again, volunteers, this broader community of folks to really make sure that that we from the beginning and continue to get supplies and resources out to our unsheltered homeless population here in Alameda County. We worked from the beginning, really working not just with across our kind of county departments. We are, our Healthcare for the Homeless program is unique to many Healthcare for the Homeless programs across the country in that we're actually embedded in our county health department. So we work in very close collaboration with our partners in public health, but and so really work with them on developing materials and protocols. Again, really while public health department managing that larger, of course, messaging information out, really wanting to make sure that we worked with our colleagues in healthcare for the homeless programs across the country to make sure that we not only developed, but continue to kind of update and work collaboratively to share information and resources out to our community. So have really robust resources, everything from kind of protocols for shelters and outreach that we kind of continually update and share out. Next slide, please. So along with the education and information and kind of supply distribution that we have done kind of throughout to really, again, work on that prevention as we kind of move through the trajectory of this. Project Room Key in Alameda County, of course, is part of kind of the California State Initiative. Here in Alameda County, Project Room Key has helped us provide temporary housing to unsheltered residents of our county as part of our COVID-19 response. We conceptualize Alameda County Project Room Key in two buckets. One is Operation Comfort, which is our isolation quarantine. So making sure that we have a space for individuals, both in sheltered and unsheltered homelessness, to be able to come in during that isolation and quarantine period. And to date, we've served over 1,900 individuals in our Operation Comfort. And so again, it's that short-term window of time, average length of stay around 10 to 14 days. And notably now we are also providing vaccine at exit. So it's a place for folks to come in during that time of isolation quarantine and then receive vaccine as part of the kind of exit and support there. Safer Ground is the second part of this. This is this much larger initiative to be able to provide temporary housing to our most vulnerable county during this pandemic. And to date, we have served over 1,500 individuals and continue to bring folks in and really working hard on exit. So it really has also become this tremendous effort in terms of us not only bringing people in, first and foremost as part of our COVID-19 work, but then really providing much deeper healthcare and housing services while they are there. And so to date, over 500 individuals have been successful in transitioning out into permanent housing. Next slide, please. All right. So along with really our outreach education and kind of these interventions to bring our most vulnerable inside. We also have worked in collaboration with our county health department on having a really a very rapid response to outbreaks and encampments. And I will say we use this word outbreak. For us, it's really a hair trigger. So at the point that we hear that somebody is reporting symptoms, may have been in close contact with somebody, we really launch a really robust response to that. In both sheltered and unsheltered environments, that really starts with kind of an environmental scan, understanding what the dynamics of the site look like, and then really working on deploying resources, as we will talk about on the next slide, being able to support folks in going to our isolation quarantine hotel, those who that may not be the best option for, supporting them in what we call kind of enhanced shelter in place, bringing resources, food, solar phone chargers, et cetera, to really support folks in being able to isolate and quarantine in place, but also keeping them and others safe, deploying testing, increased supplies, really whatever is needed to really help support. To help support that. And we have really seen in our community, thankfully, I think through this tremendous community effort, really have not seen some of the larger outbreaks in sheltered environments that there have been other places, due to this fact that it really is at that lightest, the first touch that we really are jumping in to respond. Really work close on with our public health department also in terms of supporting contact investigation, contact tracing, for homeless individuals, really also from early on, really working to make sure that how we identify and classify homeless individuals, checking through records, seeing how we can help support kind of contacting those individuals. This has really also been, again, a tremendous collaboration across county departments, across our city-funded, county-funded providers to really make sure that we are kind of providing a very coordinated response. And that we make
Lucy,
sure that, yeah.
This is David from Healthcare for the Homeless. I finally got in the meeting. I wanted to throw in there just to make clear that our rapid response happens before contact investigation, before public health would step in. So we're really the first line of responding to possible outbreaks or actual outbreaks or positive tests in shelters. And that's a huge difference, because once you follow the regular contact investigation, that's like 3 or 4 days sometimes delay, and they, in general, contact investigations at sites don't necessarily happen until a certain number of positives are met. And we jump in with like a zero tolerance kind of response as quickly as we know it from our community of providers that relate back to us for that really rapid response. I think that really needs to be kind of emphasized. Thanks.
Yeah. Thank you, David. And yeah, thanks for making that really explicit. So again, really exactly the kind of traditional public health response, certainly, especially at times when things were more bottlenecked here as they were other places, us really being able to, as David said, not waiting. There's not that delay in waiting for a confirmed positive, confirming close contact, that it really is at that and those first sign of symptoms, us really jumping in often several days ahead of our public health department and then feeding them information to support their work. And we really have, this has been we have developed and kind of continue to change our process over time, really working to make sure that our responses are flexible, in particular, I think, in unsheltered settings. And notably here in Alameda County, like many other places, we have very urban, condensed areas of unsheltered homelessness and then very rural areas. And so really wanting to make sure that we kind of also remain flexible to what's going to work based on the geography of the area. Next slide, please. And I'm going to turn it over to Seth Gomez, our senior pharmacist, to take it from here.
All righty. Thank you, Lucy. Can everyone hear me? Yeah. Yes. Okay. Great. Yeah. So as part of that response effort, we want to make sure that we act, very quickly deploy resources, testing resources as part of that effort. As part of our coordinated response involves other partners like public health or other pieces of our response, but we also actively deploy staff internally and both with partners to provide testing, COVID-19 testing. And we do that in one of many ways. One, through our rapid response efforts by providing COVID-19 testing in partnership with results generated by our Alameda County Public Health Lab, and recently have adapted to include rapid COVID-19 antigen testing as part of our response. And we're very excited that soon we'll be offering rapid PCR as part of that testing strategy as well. And then we've also established what we call our community care sites, which are spaces where we visit regularly at regular intervals to provide ongoing surveillance-based testing. And so our testing is both deployed in response to provide and support an active investigation of an outbreak or people who are persons of interest, but also a key part of this is testing via surveillance. And then we also, through our partnerships with public health, certainly is a key partner in all this work in coordinating both positive tests as a result of testing, but also to support each other in how we collectively respond to those particular events. As we know that we perform these test strategies in all sorts of locations and geographies across Alameda County, but of note, we also support testing initiatives over at our Project Roomkey, as Lucy previously mentioned and described, both in the two buckets that were previously described, our isolation and quarantine sites, and in our safer ground hotel sites. Sometimes this is deployed through internal resources, but also in partnership with Alameda County Public Health to perform testing at those sites. Collectively, we've administered over 7,500 tests throughout the county. Next slide, please. Similarly, in a more timely initiative that we have been involved in around our COVID-19 response includes the deployment of providing COVID-19 vaccine services. Alameda County has supported this initiative in many ways for people experiencing homelessness, but it always starts off with providing accurate educational material and factual information for the communities that we serve. And so we've done that in many ways, but that we've hosted several different types of COVID-19 vaccine webinars to ensure and promote comfort among providers and staff throughout our networks to help them become vaccine champions and support the uptake among the clients that we are all serving. We've also maintained our Alameda County website to include our updates and materials that we have either sourced from other places, but also internally developed ourselves. This educational material was developed with feedback from individuals with lived experience, which I think is key in helping to provide information that is both sensitive and culturally informed and also has the voice of people who have lived experience. We also embed resources at our vaccine events to include a staff member that is always available for questions and answers for people who might be either on the fence or just want to talk about the vaccines. We want to make sure that we have staff available for people to interact with to get those questions answered. We're extremely flexible. Like all other parts of our program, our vaccine response is extremely flexible and is responsive to changes on short notice. For example, like what just happened with the Johnson & Johnson pause. And so we adapt to those very quickly and deploy new resources and information and materials to help combat that. Next slide, please. As part of our response, we like to prepare our sites appropriately by making sure that they have access to the materials that we have developed, but also offer coaching and a pre-site visit with our Healthcare for the Homeless staff members. And during the coaching and pre-site visit includes supporting those sites with our shelter provider checklist, which includes all the elements that are key to help make sure that a vaccine event is successful. Some of these elements certainly include having coordinated outreach to our target population prior to each event, both the staff, the clients that are part of the particular facility that we are working with, but also doing outreach in the surrounding area. We also have expanded coordination and partnerships to help us deploy vaccine services across our county. And so those resources are really critical to help us scale our vaccine reach to all people throughout Alameda County who are experiencing homelessness. So some of those coordination efforts involve leveraging vaccine providers through Alameda County Public Health, but also local pharmacy partners that will help us deliver vaccine services in various parts of the county and in our shelter systems. Next slide, please. We have a multifaceted service delivery model when it comes to vaccines. We certainly target those fixed sites that we are already working with, including the shelters and also Project Roomkey, both, as Lucy mentioned, providing vaccines on exit, our isolation and quarantine hotels, but also offering vaccines to those folks who are in what we call our safer ground hotels, or people who are at high risk for having severe outcomes should they get COVID-19. We do vaccinate directly in those shelters, either Healthcare for the Homeless staff or through our partnerships, in order to expand and really leverage and maximize the workforce to get vaccines out there in our community. We also are introducing an expanded service to our community care model by identifying high need sites where we can really draw down, have a high yield of people who may be unhoused and interested in getting vaccinated. And we would continue these services at those sites on a recurring interval. We also have a range of street health medical providers or teams who are supporting us in the initiative and bringing vaccines directly to those folks who are unsheltered, homeless, and who are living in encampments and other places not meant for human habitation across the county. And then we also have coordinated with our county vaccine response in that we've collaborated to make it easy for people experiencing homelessness to walk into established points of distribution and to be able to self-attest to their homeless status in order to help get them in lieu of having other forms of ID that would otherwise require validation. And so these multifaceted service delivery models have really helped us not only just be flexible, but scale and also be very strategic about offering vaccines in various parts of Alameda County and offering different access points for people who are experiencing homelessness. To date, we've given over 3,000 vaccines since March 1st, and that will continue to grow. I believe that is my last slide, and we are around for questions and answers.
Thank you so much, Lucy, and thank you, Seth. I just wanted to follow up with one item you mentioned near the end there, which is about bringing vaccines to people in unsheltered locations. Can you talk about how that's worked? I think that's a lot of the vaccination efforts to date have been sort of site-focused, and I think people are sort of inching into the task of bringing them to people sort of on a more mobile manner to where they are. Can you talk about how is that going? Any sort of tips you want to share with us about key factors to make that work better?
Yeah, those are really good questions. I would say that overall, since introducing vaccines through that service delivery model, it has gone incredibly well. We with our street health model, internally, our own Healthcare for the Homeless team it has targeted 2 days per week to specifically offer vaccine services. And while those other days, while they're out there in the field, they are outreaching and educating, getting and soliciting interest for the people that they're already serving. And so our goal is to be able to offer this vaccine as part of all, to integrate it into all the services that they are already providing. And that in the current delivery model, it is a mobile model in that sense. And that the biggest tip I would suggest at this point is that, each day that our team is out there offering these vaccines to those unsheltered folks, we anticipate somewhere between 5 and 15 vaccines are what's going to be administered. So really starting out with low volume and reevaluating what that looks like as we gain traction, and as more people get vaccinated, more of our clients are going to become interested or have questions. And so being available to always answer and address those situations is really needed. I would also say that although offering vaccines in the morning is sometimes hard for our clients, where mornings may not be the best time for them, it is a balance between having and offering vaccines and balancing that with the possible situation where you have extra doses and you can't find an unsheltered person to put that vaccine in someone's arm. So because of that, we try to balance that out by offering the actual vaccine service delivery sometime in the middle of the day to give us that balance of hitting the most amount of people who are unsheltered, but also finding ways to better use those extra doses should they be generated.
And this is.
And I would just, go ahead, David.
Yeah, I wanted to say that, we have this relative luxury from the last 3 years of really hard work putting together a network of street health teams that cover every part of our county, 14 different teams that we're directing right now. So we have that coverage of the county already set up from street health teams, and adding on the COVID testing and then the COVID vaccination on top of that. And that's been super helpful for us to be able to get that street presence and be able to get those vaccines out there on the streets. And that's a whole other story in itself. How do you end up with 14 different street health teams covering a different geographic zone of your area?
Great, thank you. And Lucy, did you have anything you wanted to add?
Oh, thank you. Yes. I would just say in terms of tips, I think what's really important, as Seth was talking about kind of like starting with a low number of vaccine as you start providing field-based vaccine. And again, going back to that collaboration with fixed sites, right? And so that I think is really understanding, again, we have very dense, concentrated homelessness in areas, and then we have folks very spread out in our more rural areas. And so I think that's where it's really making that plan and that relationship between kind of being able to flex and provide that, right? Going out directly, street medicine, street-based teams going out directly into unsheltered spaces, and then being able to have a relationship with a site that, that soup kitchen in the afternoon or whatever it is, so that you can use the number of doses starting with a low number, whatever the number is you start with in unsheltered spaces, and then being able to really have that support and an event in the afternoon, because I do think there is obviously the logistics and considerations around making sure that you are have a plan to be able to use all your doses. So I think that collaboration is really key.
And a final note, just around the suspension or the pause of Johnson & Johnson, that affected our program, has affected us this week pretty intensely, because we are really focused on Johnson & Johnson, and we've managed to really quickly pivot to number one, to keep providing vaccinations and do the Moderna or the Pfizer, in our case Moderna vaccinations. We've convened a bunch of providers, shelter providers and outreach providers and patients to talk about our messaging and our communications. And we've rolled out communications to all of our networks of providers to give them very accurate information to show that to let them know what's going on and that we're really on top of this and taking care of this. So rolling with the punches as always, something new every week.
Great. Thank you so much. It's great information, and we're going to, if you have a question for our Alameda guests, please go ahead and type it into the chat window. I know they're going to hang around and help answer some questions. Thank you so much. Great presentation, a ton of great content, and definitely appreciate your joining us today. We're going to turn things over to our next community presentation about vaccine confidence. I'm very happy to introduce Alice Minervino from the Connecticut Department of Mental Health and Addiction Services. So I'm just going to turn things right over to you, Alice.
Thanks, Norm, and thanks everyone for having me today. As Norm said, we in Connecticut have been working on what we're calling vaccine confidence, rather than, I think, kind of focusing on the negative. Vaccine hesitancy is what people often say, but we're talking about vaccine confidence. We're really trying to build that confidence within our community and really try to help folks see the positives of why the vaccine is going to be helpful. And so for us, can you go to the next slide, please? For us, it starts with a plan, right? And I chose this sort of picture because, as David mentioned, we have to roll with the punches. So plan A may not have worked out, plan B might not have worked out, and you might be on C or D at this point. So we have to keep moving it along. And so really, you know, starting as soon as possible, starting at the beginning, having a place to have people staff talk about what's going on, making a plan to figure out how to roll it out, whether it's for folks who are experiencing shelter homeless, street homelessness, or in supportive housing. And really acknowledging the fact that people are scared. People have been scared for a long time. People are scared about the vaccine. And so really kind of figuring out how do you get the information and how to discuss it with folks, right? And really our job is to remember that we are here to build hope and confidence and show the competence of the work that is being done in the scientific community, with the pharmacies, with the mass vaccination sites, and remember, as staff, you know, we have to rely on a lot of the skills we've relied on for years: our motivational interviewing, our you know, meeting people where they are, and really kind of being the place to start this work. Next slide, please. And I think to, you know, Alameda County's point, in Connecticut, we really started with a lot of testing in the beginning. I think that was the place to start. We had testing sites all over the communities. We had our staff get tested. Sometimes they got tested with the clients, really to show that while it was scary, if folks worked on this together, that was how we were going to get through this. You know, and the same as with this, with the vaccines. You know, why is it important? We're part of something bigger. This is community-wide. You know, what you're doing for you is really helping others too. It's helping the people you care about. It's helping the people in your community. And really, you know, hear what the clients have to say. You know, really listen to what they're saying. Why is there some? What are they scared about? What's important to them to make it? Want them to get the vaccine. You know, we've been in this crisis for a long time, and it really does affect how people are thinking. There's a lot of misinformation or maybe not accurate information that is out there. So people need time to hear the information and absorb it. This is really new to all of us still, even though we've been doing it for 14 or 15 months now. There's still a lot of new information that comes out. And so to allow somebody to have that place to rest and listen and absorb it and make decisions. So next slide, please. So, you know, we're talking about building confidence. So what do you need to help build that confidence? Sometimes you don't know the answer, and sometimes the answer is we'll have to research that together, or let me find out and get some information and bring it to you. You know, we don't have to have all the answers all the time at that moment, but really, and being honest with our clients is the best way to move this work forward. I don't know the answer. Let's look at it together. I don't know the answer, but let me find out and I'll come back to you. Also, we've talked about there may be staff members who are reluctant to get the vaccine, or they're not going to get the vaccine. Probably not the best staff to be working with clients to talk to them about vaccine confidence. And that's okay, right? So you can say, this isn't where I have my strong suit, this isn't what I feel comfortable talking with, and letting that person work with someone else. You know, people know when you're not being genuine and authentic, and in this case, we really need that. I mean, we always need that, but we really need to be able to express how important this is. And so, really having folks work with people they trust is really important. I know everyone on the call knows this, but, stress and consequences don't really build confidence. So again, focusing on the positive, focusing on the confidence building, and use the tools that we've had in our repertoire for many, many years: confidence rulers, decision balance sheets, and our harm reduction techniques. Like I said, somebody may have to have the information given to them a couple of times, or talk about it, or talk through it. And that's okay. I think it's all about building, I'm all about building relationships at work, at home, in the community. And so this is a building a relationship and a building a confidence way to go about things. Next slide, please. So I think, as David mentioned from Alameda County, there is the Johnson & Johnson hiccup, and I think that's really probably what it's going to be. And so that might suspend vaccines or mass vaccine sites, and so it may delay some things. But, really it's also an opportunity to talk about discussions about the sort of apprehension people might have. It's a time to talk about, they had these small number of cases that had had some really adverse reactions and things, but rather than just going forward, they're taking a step back and really making sure that it's safe for the majority of the folks that get it. And so that could be used as a confidence builder as well, that they're not just blowing through and kind of doing this to the harm of people, but really wanting to make sure it's safe. Motivational interviewing now is a really good place, really figuring out where, people may have been in that pre-contemplation or contemplation phase, and now they're sliding back. They were in an action phase. They were going to get the vaccine next week at a mass vaccination site, and now they're not so sure they're going to go. And that's really the time to kind of build on that work as well. So as scary as the pause may be, for some folks, it does lead us to an opportunity, I think. Next slide, please. So I put this in here because I really like this as a way to help debunk and have some myths, kind of a document that people could have for folks, and it shows a lot of the some of the myths that are out there, and some of the and really the facts to help somebody talk about the myths. It causes severe side effects. Well, in most cases, they're very mild. They only last a few days. And in some cases, people don't have any. And so really to kind of talk about what the word on the street is and have a document that really tells you, counteracts some of that word on the street. Next slide, please. We also really want to talk about, my job that I have, a lot of the work I do is supporting our staff and supporting our funded providers. People are tired and scared. Like I said, we all know we've been doing this for a long time. And so, people have their own reactions to things, and they're still expected to come and be at work 100%. So sometimes it's frustrating to, have these hiccups, to have people not kind of follow the trajectory that you're hoping they follow. Listening can be very hard. So, having a place where the staff can also talk about their apprehension, their nervousness, their frustration with Johnson & Johnson, how it delayed things for their clients. And really, supervision is very important now, and also peer support. We learn a lot from our peers, and I think for most of us, at work, we have a lot of folks, or, often we have folks that we really rely on to help us. And so it's really important, and especially in this time where, some of us are still working remotely most of the time, or at least part of the time, to have a way to have a staff meeting or a debrief or something to help people kind of with all this stuff that's new to them. a lot of our folks have had medical issues, severe medical issues that we work with, but this is different. This is a different approach that we have to take. So it's just really important to help support the staff. On the next slide, I'll talk a little bit about what Connecticut has been doing. So through, I put the FEMA logo here because through some grants from FEMA, Connecticut's received funding, and we call it COACH, which is the COVID-19 Assistance for Community Health. And it really was funding from FEMA for up to 9 months now that is focused on doing outreach that is solely outreach related to the pandemic and helping people connect with services, whether that's medical services or other things because of trauma that they've sustained through the pandemic. And it's been really successful. The target groups for our COACH programs were for folks experiencing homelessness. So we worked really closely. We too have a shelter decompression programs, and so we worked closely with people in shelter to help facilitate all the referrals to the resources. We've been doing ongoing trainings. We actually, in our continuum of care, one of our continuum of cares in Connecticut, we've modeled after the COVID office hours from HUD, and we have CT Boss office hours once a month, where we talk about, we have community presentations, and we also do some, deeper dive into more technical stuff. And really, we've partnered with a lot of great other agencies and state, local, and federal partners. And we're really doing outreach and support at vaccination sites, primarily through our COACH program. Our COACH program's been really successful to the point where Connecticut, our FEMA money is going to be ending, and so Connecticut's taking on the lead to fund COACH once the FEMA money is no longer available to us. So we really found that to be a very important connection to folks. Next slide, please. So our partnerships, and in my haste, I forgot a really important partner on this slide, and I'm so embarrassed to say that. But our federal partners, as always, are HUD and SAMHSA and HHS and FEMA, providing funding and flexibility along this path for the past year plus. This has been really helpful. Our state has also been a great partner. Our governor's office, our Department of Public Health and Housing and Social Services. But the agency I'm forgetting, and I didn't put it on there, was our Community Health Center. That's actually the name of their health center, and they've provided an enormous amount of testing throughout the first year of the pandemic. They are providing an enormous amount of vaccination clinics now, and they've provided us with a lot of training, a lot of support around the COVID testing, the support around the vaccine confidence. And so I can't say it enough. I'm remiss that I didn't put their name on the slide, but they are a great partner to us. So next slide, we have some coming attractions, I think. So in Connecticut, we're partnering with our Department of Public Health to really roll out a couple of different initiatives that are going to help equip the community leaders with information on vaccine and key messaging. It's going to create a place for dialogue and best practices. It's going to, as it says here, amplify our efforts to organize and scale the outreach and communication strategies, and really new ways of messaging things where there are distinct needs. Again, I think back to the COACH where, seniors and folks experiencing homelessness, we really targeted the outreach efforts to them and their specific needs. So some of, next slide, please, Mika. So some of the things that we're doing are trusted messenger forums. I say this globally, the Department of Public Health. And really, that's going to be very targeted, smaller group ways to talk with people who will be the trusted messengers of this information. There's going to be clinician speaker bureaus where clinicians talk about the vaccine and the vaccine, building vaccine competency. They have folks speaking up to 70 different languages, clinicians that have, so there's obviously a very wide variety of languages that are going to be spoken. And so that really it's targeting anybody who are trying to target as many people as possible. And then new toolkits and messaging resources. So in one of the slides upcoming, I have some links to the resources we have, and one of them is there, but it's really important to note that, how important it is to get messages out there that people can understand in their own language, people can understand from the people they trust and feel safe with. And having, this is a unique experience, as we all know, having different ways to do the messaging. This is new ground for all of us. So I did want to share a couple of, I think I have 3 success stories. So if you go to the next slide, we can look at that first one. So one coach staff that I had talked to was saying how a family was really, very hesitant. It was the whole family. They weren't sure about getting the vaccine. And so the coach staff really brought them information, brought them easily understandable and digestible information, facts, and talked with them and really built their confidence. The whole family went and got vaccinated, and they were so happy and pleased with the information that they got from the coach person that they took additional resources back to their community so they could share with others, so they could be the trusted messenger before the Trusted Messenger initiative had even started. Next slide, please. There was another where a client had was at a vaccination site and had a bad experience. Someone passed out. They got nervous. They didn't want to go to their second shot. The staff went and talked with them, went with them to the second vaccination, and really was able to not only help support the client through that second vaccination, but talked with others that were in line. And this is a mass vaccination site. So over 500 people were vaccinated at that event, and the case manager was, felt confident to talk to other people, even though it wasn't just their client that they were addressing, but really helping the community at large. I have one more success story. We can go to the next slide. And this one is really about someone who was older. The daughter was very concerned that her father wasn't going to be able to get vaccinated. And so the staff worked with the woman and her father to register for a homebound vaccination appointment. So this person was really reluctant, but having that somebody be able to come to their house was able to ease some of their worries. So I think, thinking about different techniques, everyone's going to be a little bit different. Their stories are going to be different, but what are ways we can be creative and think about different options for folks? Some people, a mass vaccination site might be feeling really overwhelming to have 500 people. So maybe work with them about going just to a pharmacy where they can do it a little bit less people in line. Sorry, next slide, please. So I kind of alluded to that in the tips and tricks. So work with folks around, sometimes people aren't really computer literate and they might have a hard time navigating the VAN system or their individual pharmacies. And so if the staff can sit with the clients, the tenants to do that, that would be great. Some agencies have contracted to hold their own vaccination clinics. And again, if staff and clients are working together, clients can see the staff have gotten their vaccination or they're wearing their stickers. That would be really great. Staff can talk about the process and assist in the registration. And also, sometimes it's just the familiarity. So if there's a place that somebody knows, so for instance, our community health center, if a client goes to the community health center, maybe try and get them their vaccination site there so that they have a little bit more of a comfort level. Next slide, please. So this is the link slide that, and I sent it to Letitia, who I believe will get it out to everybody, but it's also in the slides. But it's about our frequently asked questions. It's related to our coach stuff and some state of Connecticut materials. Again, more educational, some fact sheets, some of the upcoming stuff that we're doing related to the trusted messenger forums and the toolkits. So at that, if we could go to the next slide, I can pause for any questions.
Great, thank you so much, Alice. Great presentation. Again, a lot of fantastic content. You talked a lot about messaging, and we coincidentally did a little thing on messaging and showing the results of some of the couple of sort of small studies we've done on what messages have worked. Can you talk about, like, what were the messages that sort of really resonated with people?
So I think the facts, right? So really being able to address any, I think on one of the slides it said, like, if women get vaccinated, that could cause infertility. Really researching and showing that is not the case. Another example I've heard is that the vaccine will change your DNA. Well, the vaccine can't change your DNA, and this is why. And so really focusing on these sort of like very scary sort of myths that are out there, and really being able to have the scientific and researched answers for folks has been really helpful. Again, I really believe in, like, telling people the most truth that you have and you can, and having the information to back that up.
Yeah, thank you so much. I will say a vaccine that changes your DNA, I think, is the plot of most horror movies and zombie movies these days. So yeah, it does sound terrifying. Thank you. So we're going to go on to, again, if you have any questions for Alice, please type them into the chat window. She'll be happy to answer them for you. But we're going to move on to our next presentations. So we have a regular CDC update with some bonus content today. So I just quickly want to introduce Sapna Morris and Ashley Meehan from the Centers for Disease Control and Prevention. So I think I'm turning it over to Ashley first. So Ashley, take it away.
Thanks, Norm. Hi, everyone. My name is Ashley Meehan, and I am on the homelessness unit within CDC's COVID-19 response. And I'm so glad to be here today. Next slide, please. Alrighty, so as of April 14th, there have been approximately 31.2 million cumulative cases of COVID-19 in the U.S. This graph shows the daily trends and the number of COVID-19 cases reported to CDC. So the blue bars show the daily cases, and the red line shows the average number of cases over the last 7 days. So over the past few weeks, we were sort of seeing a plateau, but it appears that cases may be increasing. Next slide, please. All right, so this map shows the number of total COVID-19 vaccine doses administered per 100,000 population by state. Overall, approximately 125 million people have received at least one dose of the vaccine, which comes out to about 38% of the total population. The states with the darkest shading have administered at least 60,000 doses per 100,000 population. And so with that, it brings us to about 48% of the population over 18 have received at least one dose, and 80% of the population over 65 have received at least one dose. Next slide, please. Alrighty, so we know folks are anxious to, get back to normal and open things back up, but we continue to recommend our current guidance. which can be found on our website. Our website has a lot of resources related to COVID-19 and vaccinations. Our current guidance is on there, and we have frequently asked questions about COVID-19 and COVID-19 vaccinations. And so the links to those resources are included on the slides, and feel free to look at those whenever you are able. Next slide, please. All right, so before we conclude, I would like to pass it over to Dr. Sapna Bummer-Morris to talk about what the pause in the Johnson & Johnson vaccine means.
Hey everyone, I'm not sure if you can hear me or see me.
We can both hear you and see you. Thank you.
Well, fantastic, Norm. Nice to see you. It's been a while.
Nice to see you.
So I'm going to be very, very brief. And then what I'd really like to do is be able to answer some questions if folks have them. And we'll do our best to share what we know and kind of where we are in the whole process. So I want to just start by saying that as unfortunate as this news is and the pause is, that this is definitely our vaccine safety system working. I think David Canavan said that to me best. So, we are actively monitoring side effects and severe consequences of vaccine through our VAERS system. It's a system that looks at vaccine adverse events. It's called the Vaccine Adverse Event Reporting System. So it's looked at frequently. We monitor for all adverse events related to vaccinations, every vaccine, but obviously the COVID vaccines right now are our primary concern. If y'all got your vaccine and you were offered to jump on the app called vSafe, there are mechanisms by which you can report your symptoms. That feeds into the VAERS system as well. And these adverse event reportings are exceedingly important for us to understand kind of the post-marketing experience. When folks do their vaccine clinical trials to get emergency use authorization or FDA approvals, those trials are done in tens of thousands of patients. And usually you should see adverse events start to trend. But as you maybe heard very, very early on, there was concern about anaphylactic reactions or very severe allergic reactions. Turned out to be not really associated, but we needed to kind of monitor those. And, it's only after giving millions and millions of doses that we are seeing these, kind of rare events. And when these rare events are frequent enough or trend enough, and then, and have potentially very severe or fatal potential, that's when we need to kind of stop and take a look and think about what's the right thing for everyone in terms of safety. So I want to just kind of comment so far on the fact that this is a fairly rare condition, this type of clot. So what was discovered were 6 cases of what's called cerebral venous sinus thrombosis. Now, cerebral venous sinus thrombosis does occur in the general population. We do see it. It's rare. But in particular, it's basically a clot formation in your venous system within a part of your brain. But in particular, this clot was formed while having with a low platelet count. So that particularly kind of alerts us to think about why would this clot form with also what's a low platelet count. So that usually signals to us that this is as a result of something that's changed in our immune system. So it does trigger us to think more about it being vaccine related. So it occurred in 6 people. They all were women. They all were between the ages of 18 and 48. And this can lead to very severe illness. A number of these patients, all of the patients also had thrombocytopenia, so a platelet count lower than 150. Dangerous bleeding occurs when your platelet count is below 10. So it wasn't so low, but again, it was trending in the low kind of, we would call it a low platelet count, but not a necessarily dangerously low platelet count. The events happened between 6 and 13 days after the vaccination. And this is a very difficult condition to diagnose, and it's difficult to treat. And again, so the consequences of not recognizing it, can be very severe. So the pause was in part because we want to make sure that if for those people that have the 3 million or so that have received the Johnson & Johnson Janssen vaccine within the last couple of weeks, we wanted to make sure that we could follow those patients out and ensure that no other events take place. And then, we'll be able to take a further look at the information and the data, and then kind of make a decision about what the safety, right decision for going forward with the vaccine is. And there was a call yesterday by CDC staff, and I think Dr. Oliver presented it well. The most conservative thing to do would just say we're just going to stop using the Johnson & Johnson Janssen vaccine, which is a possibility after they look at what happens. They could say that this is not really a signal event. These were rare enough, and they didn't occur as associated with vaccine. If they do further investigation and could decide that we should continue to use this vaccine because the benefit outweighs risk, or they could decide something in the middle, which might be something like they will use it for particular age groups, or they'll use it for particular demographics, but not necessarily use it in the entire population. Again, the folks that did have these severe complications were 6 women, all under the age of 48. So, I think that's partly why there's been this pause. They want to see investigate the cases, put all the information together, and then weigh in on what the best course of action is. So I'll stop there unless Norm or others think that do we want to hear more details about what happened? And I'm happy to just answer some questions about it.
Stephanie, thank you so much. That is incredibly helpful information. And I know it must be unbelievably challenging to try and balance all these, the risks and the benefits and all the sort of considerations. So definitely appreciate all the work you've done to both communicate that to us and to just sort of work on trying to figure this stuff out. I wonder if you could give us advice about, as we're communicating externally, all the people on this call, and we're communicating with people experiencing homelessness, with our providers, with our healthcare agencies, what sort of the simple message that you would recommend that we deliver about the Johnson & Johnson pause? Obviously, the incidence of side effects are still quite low, so we don't want people to, for there to be a mass panic about this. But can you talk about what message would you recommend we sort of communicate to people about this?
Yes, I would say the first message is that, our goal is to ensure that vaccines are safe. We have post-marketing systems, these systems in place through CDC and FDA, as well as through the companies, to monitor what happens after people get vaccine. This all occurred and was reported within a couple of days. So this all happened very quickly, which is the system working. So we identified a trend. If you can imagine, there's been over 6 million doses given of Johnson & Johnson Janssen vaccine. And within those 6 million, they were able to identify these 6 cases where this happened. As soon as it alerted, I think even after 3 or 4 cases, the advisory committee on immunization practices started to come together to meet on this. And so, again, these cases are being actively investigated. I think we are going to learn more. I think the prudent and responsible thing to do is to pause until we know more information. And again, this has been exceedingly rare. I think the fact that it happened in 6 patients and all were women in a certain age group, I think speaks to potential risk factors. And so, again, I think the key messages are that we are monitoring for safety. This was noted quickly. The pause is the, kind of the way of us taking a step back and ensuring safety, and trying to make sure that these cases are investigated properly.
Great, thank you so much.
I do believe that the experts that are getting together will, consider all kind of aspects of what could happen in the potential as they make their decisions on whether or not to pause entirely or for a longer period of time.
Great, thank you so much. Great information. And if you have questions for Sapna or Ashley, please go ahead and type them in the chat window. Thank you so much. So we're going to move to our next presentation to try and stay on track here as far as time is concerned. I'm happy to introduce Sharon Singer from the SNAP's office. She's going to talk about some resources and also give us our regular update on ESG COVID spending. So Sharon, over to you.
Hi there. Just to let folks know about this brand new resource, it was just released last week. It's a USDA reimbursable meal program for 18 to 24-year-olds who are in shelter, who are residing in shelter, or who are getting services through shelter. So it is a new resource. And so there are links that Letitia already put in the chat. And I think there's a second slide, and there's guidance available to being able to implement this program as well. So again, just a nice new resource for us to be able to highlight from our federal partners. So moving on to the next slide, our regular status report, we are inching upwards. We are up to 6% of funds drawn. But again, sort of slow movement on getting funds into IDAS and getting funds committed. You can go to the next slide. And thanks to Harper Sutherland from our team for doing an analysis of spending rates. We estimate that out of the 362 grantees, 81 will meet the 20% deadline at current spending rates of September 30th, 2021, and 15 that will meet the 100% deadline of September 30th, 2022. So that means that we need to change this trajectory. And then we will not name the jurisdiction that will not spend all of their funds until March 28th, 640, I don't even know how to pronounce it, 6,474. I don't even know what the world will look like then, but I'm pretty sure these ESG CV funds will not be around. So all that said is we are going to work with you all to change that trajectory so we all can meet that 2022 deadline. And lastly, we are going to go to the poll that was today's. You can still, it was just put in the chat by Micah, and we just wanted to know who is on the call. We've asked questions the last few weeks, and we wanted to get a sense of who is on and who we can help with. So very exciting. We have, it looks like the majority of folks on this call, or I should say, oh, the numbers keep going up and down. This is very exciting. Keeps changing. So, I feel like I'm that guy on MSNBC, like with the real-time data from the elections. So at this very second, we have 30% of the folks on the call are ESG CV grant recipients. We have 45% or thereabouts are COC organizations, and we do understand there is overlap there. And we have 7% sub-recipients or sub-recipients. We got 5% HMIS, 6% HUD TA providers, a bunch of HUD employees, we've got 8% on here, and then we have a program participant, 1%, and then other, and we know some people who met several of these criteria were in there. So we really appreciate you sharing who's on the call. It's great to have you here, and we will come up with a good poll for next week to keep you engaged. Thanks.
Thank you so much, Sharon. And just want to say that it's helpful to us because we're trying to get a better sense. We want to provide the best content for you on these office hours calls that we possibly can. So that just gives us a sense of like what your various roles are, and will help us try and figure out what kinds of resources and discussions and presentations we should be offering. So thank you so much, and you can keep filling that out. We will sort of get the results after this call is over, but please feel free to keep filling it out. Next, I want to introduce Marlisa Grogan from the SNAP's office. We just published a new waiver, and she's going to talk about what it says. So Marlisa, over to you.
Hi, everybody. Great to be with you and to talk about this much anticipated waiver related to rapid rehousing for ESG-CV. So it was issued April 14th, and it's actually retroactive to the date that the ESG-CV's community or the ESG recipients community began preparing for COVID. Just as a reminder, that would be, we're assuming it's no earlier than January 21st, 2020, but you would need documentation such as call notes or something identifying the date that your community began its COVID response. And it allows ESG-CV rapid rehousing projects to serve individuals and families already residing in housing who are receiving some sort of time-limited rental subsidy funded by another source, such as coronavirus relief funds, SSVF. It could in some cases even be continuum of care rapid rehousing, who were homeless prior to entering that housing. And so this program that's providing the current rapid rehousing assistance has to be, or rental assistance has to be targeted for people experiencing homelessness. So when serving this newly eligible population, recipients can accept inspections, habitability or HQS inspections that were conducted by other providers. So that's actually the second waiver, which I'll go into a little bit more detail about in a minute. Next slide, please. Okay, so this waiver is applicable to both ESG-CV funds as well as annual ESG funds used to prevent, prepare for, and respond to coronavirus. There are specific criteria in the notice that recipients need to follow in order to make the annual ESG funds applicable, or for you to be able to use annual ESG funds under these flexibilities. If you are, you'll see that if the criteria in the notice does involve an amendment to your annual action plan submission. Just a reminder that that amendment is exempt from consultation and citizen participation for fiscal year 2020 or prior year funds, only to the extent necessary to amend recipients' plans to include this newly eligible population and make corresponding changes to your written standards. So you don't need to do consultation on that amendment, but you do need to publish your plan online. Next slide, please. So these are the eligibility criteria to be able to follow up current rental assistance and switch it over to ESG-CV or annual ESG rapid rehousing rental assistance. The household must meet the definition of homeless immediately before moving into their current housing. They must have been residing in housing with time-limited rental assistance provided under a homeless assistance program. So that would be CRF, SSVF, COC, and there are likely other homeless assistance programs that could fit into this. They would not have an overlap in rental assistance between the non-ESG program and the ESG program, so you can't pay for the same month using both funding sources. There's not a gap of more than 1 month between the end of the non-ESG rental assistance and the beginning of the ESG rapid rehousing rental assistance. So you would want to go from 1 month, the last month under the last funding source, and then following up with ESG or ESG-CV the following month. And finally, the household must meet the resources and support networks criterion. So beyond an eviction moratorium, the household must not have resources or support networks able or necessary to retain their existing housing. Next slide, please. The con plan amendment requirements are that recipients can use the waiver to expand the scope of their rapid rehousing beneficiaries. So you would have to amend your con plan to indicate that you'd like to use this waiver to expand your eligible beneficiaries under rapid rehousing. And in doing that amendment, as I mentioned before, you're not required to do consultation or citizen participation, but you do need to publish your plan online. The other requirements include that for households who are currently rapid rehousing program participants, and that would be the case because you've been providing ESG funded services along with the non-ESG rental assistance, you can provide ESG rental assistance without treating them as a new applicant. So you wouldn't need to exit them from HMIS and re-enter them. They would, or do a reevaluation or redo eligibility criteria checks. You can just continue treating them as an existing program participant in your ESG program. And for households not currently ESG rapid rehousing program participants, then you do have to develop written standards for serving this population, and include ways that you're going to make changes to HMIS, coordinated entry, initial and reevaluation, record keeping, and reporting as appropriate. So we expect to provide more guidance on that shortly, but you should begin thinking, if you want to use this flexibility, how you would standardize your procedures to include this population. And then finally, regarding habitability standards, if you as a recipient are choosing to serve this newly eligible population under rapid rehousing, you can provide rental assistance and housing relocation stabilization services without doing an inspection to the unit, as long as one of these criteria is met. And that the three criteria include you have documentation showing that the prior rental assistance provider determined that the housing met habitability standards, or HQS, and that you're not providing more than 90 days of rapid rehousing assistance to a program participant. If you are going beyond the 90 days, then you would need to determine that the housing meets habitability, or HQS. So those are situations where you may not have to do a habitability inspection, or if you're going over the 90 days, then you do want to do habitability or HQS. And, I think we might be one slide behind. But yes, there we go. So those are the three criteria to consider when you're deciding whether or not you need to do a habitability or HQS inspection. And with that, I'm going to turn it back to Norm.
Thanks, Marlisa. This is, I think, one of those things that's a little complicated, but it's helpful to step back and sort of explain what this sort of a case example of what this is supposed to do. Can you talk about, like, I don't know, what an example of when this waiver would be useful? Can you talk about what an example of that would be?
Yes, I think that what prompted this waiver in the first place, and in many examples, was the use of coronavirus relief funds for rental assistance, and knowing that those funds were going to run out, many recipients were asking, well, can we follow? We know that we can only provide, let's say, 3 months of rental assistance under coronavirus relief funds. When that 3 months is up, can we use our ESG CV rapid rehousing rental assistance to continue that for up to, however, like a year, like an additional year? And we were not able to do that under ESG CV because of a couple of differences. We we could get into a lot of technical detail, but the long and short of it is that we were not able to make that transition. So this waiver provides recipients the ability to sort of marry up their funding and then continue rental assistance where the other funding is going to run out.
Great, thank you so much. So again, if you have any questions, please feel free to type them into the chat. We have one more topic we want to cover today. We are very happy to introduce Mandy Wampler from our Philadelphia field office. She's going to talk about, give an overview of CPD monitoring. So Mandy, over to you.
Hi, everybody. It's great to be on with you this afternoon. I think we actually talked about rescheduling me to next Friday because it's been a lot of content and it's the end of the day on a Friday, and I'm just not sure our tired brains can handle it. So maybe what I'll do instead is just give a preview of my preview. Next week, we're going to spend a little bit of time. So I'm sorry, I didn't introduce myself, but I'm Mandy Wampler in the Philadelphia field office. And we wanted to spend a little bit of time with you here during these office hours, helping to get you a little bit more familiar, a little bit more comfortable with the CPD monitoring process. For those of you that know that you're being monitored this year, we know it feels a little bit stressful and a little bit overwhelming with everything that you have on your plate. So it's kind of a let's all breathe together and we're all in this together type of approach to just say, this is how you should be thinking about it. This is how CPD thinks about it. And in addition to that, to share a little bit of, well, a few notes on how you can be thinking about ensuring compliance over the long term, especially for your ESG-CV program, so that if you're not being monitored this year, you can start thinking about how to get your policies and procedures really nice and tight and neat and solid, and your client files nice and organized. And so it's also kind of a forward-thinking exercise for some things to be thinking about. And that's all I can mention for now. So next Friday, I'm looking forward to it.
Great. That was a fantastic preview, Mandy. Well done. So we had several questions. I think we got to most of our questions in the chat window. So there are a couple we'll try to take back and get responses to. I see a lot of people have questions about the waiver. We will try to sort of keep those coming, by the way, and we will try to collect some responses and put those and have those ready for next week's office hours discussion. Thank you for bringing those to our attention. So we're going to wrap up here. I want to thank everyone for all your time and presenting for us today. Especially want to thank our guest presenters, Seth Gomez, Lucy Kasdan, Alice Minervino. Want to thank our friends from CDC. Want to thank Mandy, and definitely excited to hear from you next week. And all the SNAP staff and all the other HUD staff and our technical assistance providers putting this on. You guys have done a fantastic job. So thank you all, and just want to wish you a happy rest of the day and a great weekend. And that concludes the webinar.